in the very fruitful Egyptian Indian Orthopedic online course. Tonight we have two eminent speakers from India. Professor Oberoi from India will speak about the long head of biceps rupture, and from Egypt, Professor Amr Rashwan will speak about irreparable cuff, rotator cuff tear and their management. First of all, I would like to thank the Egyptian Orthopedic Association and the Indian Orthopedic Association for sponsoring this course. Many, many thanks to my dear friend, Dr. Srinivas Kambhampati, for his great effort in this course and in the previous international trauma webinar and in the upcoming international hip webinar. Many thanks to you, my friend, for your great effort, and many thanks to OrthoTV for live streaming this webinar to all the countries all over the world, and thanks to Eva Pharma Company for sponsoring this course. First, we will start with Professor Oberoi. Professor Oberoi, please, can you share your screen, sir? And Dr. Srinivas will be the moderator of this session. Dr. Srinivas, would you introduce Professor Oberoi, sir?
Sir, I'll just introduce you if you don't mind.
Yeah, sure. I can unshare that.
Please stop sharing. Yeah, thank you. Thank you very much, Professor El-ashhab, for the kind words. Good evening, everybody. It's a pleasure for me to introduce Dr. IPS Oberoi. He's one of the prominent arthroscopy surgeons from India. So Dr. IPS Oberoi is currently working as Director of Orthopedics, Arthroscopy, Joint Replacement Department at JCI accredited Artemis Hospital in Gurgaon, India, and is one of the best knee replacement, hip replacement, and arthroscopic surgeons in that area. And Dr. Oberoi is the past president of the Indian Arthroscopy Society just last year, and he's an expert in primary and revision joint replacement surgeries of knee, hip, shoulder, elbow, and ankle joints. He is one of the first and among only few surgeons who started minimally invasive reconstructive surgery for shoulder, elbow, hip, and ankle joints. In addition, he's also mastered techniques of managing multi-ligament and complex injuries of the knee. He's published on joint replacement, arthroscopy, and sports injuries in journals and textbooks, and prepared manuscripts for arthroscopy education for young orthopods. And he's a visiting surgeon to Al-Tawara Medical Teaching Hospital, Ministry of Health, Sana'a, Yemen. He's also a visiting surgeon to many other countries, including Yemen. He's invited as surgeon to medical schools and hospitals in Iraq, Iran, Oman, and Syria. And he's given lectures in various international and national meetings. He's a member of some of the professional bodies like AAOS, Asia Pacific Orthopedic Association, Orthopedic Association of SAARC countries, ISACOS, and Asian Arthroscopy Society. He's been secretary, and Indian Orthopedic Association. Thank you very much for accepting the invite to give a talk today, Dr. Oberoi. Please go ahead. Thank you very much.
Thank you. Thank you. So is it okay? Is the screen visible?
Yes, sir.
Perfect. So it's an interesting talk today. We talk about the long head of biceps rupture or long head of biceps tear. It's interesting in a way that we commonly as an shoulder surgeon see this problem, and often we find it confusing to operate or not to operate, and if at all to operate, what technology and what technique to be used for biceps tear. Most of the people which come to us are usually younger people. They usually fall on an outstretched hand with trauma leading to the long head of biceps rupture. But most of them are either heavyweight lifters in the gym, and while lifting heavy weights, they actually break their long head of biceps tendon. There are certain sports activity where after falling, especially in snowboarding, when they fall on the snow and they try to break the fall, they put pressure on their arms and they break. their long head of biceps. And also soccer also, we have seen a lot of soccer injuries where they actually fall, and while stopping their fall, they fall down and they break the long head of biceps. It's also commonly seen in elderly, but with the rotator cuff pathology. When we are doing cuff surgeries, we often find biceps also ruptured, especially with subscapularis. But most commonly, the long head of biceps is ruptured in athletic activities due to trauma or lifting weight. Most of these patients often tell that then when they were lifting heavy weight, they just heard an audible pop. We could or could not see sometimes a Popeye sign, depending upon the swelling and also the size of the arm. Some people are very skinny. You can actually see the Popeye sign or a Popeye deformity. Patients are initially painful, but overhead activity starts to become painful later on, because once the normal pain has subsided, then it's more painful in overhead activities, especially when they are throwing. The arm is going into supination and when the elbow is flexing. So these are the activities which are requiring biceps, and these are painful. The pain is often in the anterior part of the shoulder, and sometimes these patients have pain which actually radiates down to the arm, because to the belly of biceps, essentially called as a biceps cramp. The power of the supination strength as to the other side might be decreased in some patients, though it is not a very consistent finding. So most often these have a nagging pain in the shoulder after that injury, and pain is also some cramping sensation is there. Weakness may or may not be there, which might be significant. We try to decide whether to operate on these patients or not to operate, depending upon their requirements. Often in patients which are high activity level people, younger athletes going into gym, doing a lot of athletic activity, or heavy workers which have to lift heavy weights, these are the guys where we would want to actually go ahead and do some kind of repair. The repair of this long head of biceps is called tenodesis, where we are going to put the tendon back onto the bone. If you look into the picture, there are various places where we can fix the tendon back. You can actually put it right at the articular cartilage, that's juxta-articular one. You can go at the superior border of the groove, which is at the groove, or you can go either subpectoral, something down below the groove. Subpectoral is one which we commonly do, because when long head of biceps ruptures, it actually goes down through the groove. And most often than not, the patients often have a lot of inflammation of the biceps tendon in the groove. So just fixing this on the articular cartilage or at the groove doesn't make sense, because there is a pec major tendon which is right in front of it. So it is always better to go ahead and do a subpec tenodesis, and that's the most favorite surgery which is done when long head of biceps is ruptured. It's a subpec tenodesis. When you plan to do a subpec tenodesis, small anatomical points are important. One important point is that you have to identify the muscle tendon junction, and it's easy to understand that the muscle tendon junction of the long head of biceps, this is around 7 to 8 centimeters length. And this whole tendon with the junction is, if you look into the anatomy from the inferior border of pec major, it is around 3.3 centimeters. So basically you have to identify the tendon and the muscle tendon junction, and then put it back so that there is no excessive tension to the tendon. And to do that, we should know what is the normal anatomy. So as I told you, the muscle tendon junction actually extends around 7.8 to 8 centimeters down. But if you look at the inferior border of pec major, it is around 3.3 centimeters distal to it, and it needs to be identified when we are doing a repair. The incision is a cosmetic incision. It's a small incision which is at the inferior border of the pec major tendon. So you palpate the pec major tendon. It's easier to palpate. Arm goes into a slight abduction and external rotation. And a small 3 centimeter skin incision is made over the anterior part of the arm, which you are centering at the pec major tendon. So it's an incision which is a small vertical 3 centimeter incision. Subcutaneous tissue can easily be dissected out. Finger has to be put inside, and you can do a finger dissection. And when you do a finger dissection, you are able to palpate the pec major, and underneath you can palpate the groove. And when you are able to palpate the groove, all you need to do is put your finger down and fish the biceps out. Most of the time, if the tendon tear is an acute tear, couple of days old, you would be able to find this tendon somewhere here in almost all these cases. They retract, go down to the inferior part of the groove, and this is where the tendon would stay in most of the cases. So you just put your finger down and fish it out, and you can take it out. So that's how it is done. Then when you take it out, it's important to mark the proximal and the distal aspect of the muscle tendon junction. And when you mark it, you have to put interlocking stitches, something called like a Krakow stitches, which we commonly do for any tendon repair. We often use non-absorbable sutures, fiber wire, tiger wire, or sometimes even ortho sutures to stitch this muscle tendon junction, because this is going to hold well into the belly, because the biceps has got a lot of power. It can actually avulse off. So your suture fixation should be good. And we recommend at least 3 interlocking sutures, not 2, but at least 3 interlocking sutures in a Krakow manner to be put in the muscle tendon junction, which is important. Once that has been done, then you have to put your tendon back onto the tenodesis site. And we have to identify the tenodesis site. And I think as we said that the most distal part of the muscle tendon junction of the long head of biceps after tenodesis should be 3 centimeter distal to the inferior edge of pectoralis major, because that's where anatomical point is there. So which means this actually comes at the distal 1/3 of the bicipital groove. So when you have done a dissection, when you have stitched the tendon, you identify the lower part of the biceps groove and see that you have to stitch it, put the tendon back at that place. And this usually is around the muscle tendon junction is around 3 centimeters distal to the inferior edge of pec major tendon. So you have 2 important landmarks. You have a landmark of an inferior edge of pec major tendon, and you have a landmark of the bicipital groove. So in the distal 1/3 of the bicipital groove, that's the right place. And if you see the inferior part of the pec major tendon, you palpate it, just 3 centimeter distal to it should be the most distal part of the muscle tendon junction. So these are 2 anatomical features which are consistent, and your biceps tenodesis site will be perfect if you go by these 2 anatomical landmarks, which are always there. It's important to understand that there are a lot of neurovascular structures which are very close to this area, especially the radial nerve, the musculocutaneous nerve, and the axillary nerve. Now, these are plus minus centimeter and a half close to this area. So there are a couple of dissections which have been done. Depending upon where exactly you're going to put your tenodesis site, there are nerves around it. So it's important that whatever dissection is done subperiosteal. You should not do too much traction, and you should not be extra periosteal. You have to be subperiosteal in such cases. As we said in the dissection, the musculocutaneous, the radial nerve, and deep brachial artery, both are within 1 centimeter on the medial retractor. So medial retractor is very, very important. If the medial retractor, medial side, you have all these structures which are very, very important. External rotation of the arm would move the musculocutaneous nerve by around 1 centimeter away from the tenodesis side as compared to internal rotation. So that is why whenever we do tenodesis, another 2 important points is you limit the use of a medial retraction. You don't retract it too hard on the medial side, because on the medial side there is a musculocutaneous nerve, there is a radial nerve, and the deep brachial artery is there. As far as the lateral side is concerned, you just external rotate the arm slightly, and it will actually take away your musculocutaneous nerve away. So again, on the lateral side, just external rotate the arm, and I think that is a good technique to avoid a neurovascular injury. So we commonly use 2 bent Hohmann retractors. One we place medially, one is placed laterally. And as I told, it is strictly subperiosteal. So finger dissection, you put your first Hohmann on the medial side, and then you put a Hohmann on the lateral side. And with the finger dissection, you can actually take the biceps out. So that's how the biceps is out. It's acute tear. And then you identify the tenodesis site. You see that the bone is exposed nicely, inferior part of the groove. And then you remove the periosteum there. And now, depending upon the technique where you want to do, you identify the point and you would go ahead and do it. So if you do two Hohmann retractors, one medial and one lateral, don't retract on the medial side too hard. You would be able to avoid injury to the axillary nerve laterally. And as I said, the musculocutaneous and the medial antebrachial cutaneous nerve on the medial side. So these are 2 important nerves on either side. And when you go subperiosteally and put your arm in slight external rotation, you are able to protect any neurovascular injuries when you do a subpec tenodesis. There are a lot of studies which show the position of forearm while doing a tenodesis. So the patients were grouped into two groups. One is when the arm is put in a pronation and extension, and second is a neutral position where the elbow is flexed and hand is positioned with thumb pointing upward. There is no statistical difference which was noted. You can put the arm in extension, pronation extension, you can put it in flexion. As far as power is concerned, there is no difference wherever you keep the arm while doing a fixation. But when you do fixation in pronation and extension, the functional score is much better because patient has less pain, because you actually restore the length of the biceps. You don't make it too short. If you flex it, there are chances you may be tightening the biceps a bit more. And these patients often have some biceps cramps and pain by end of 3 or 6 months or so. So functionally speaking, though the position of forearm is not very important, but it is better that if you put it in pronation and extension, because long-term outcomes have shown that the patients don't have cramping sensation after the repair when you put the arm in full extension and pronation. Now, once you have identified the site where you want to fix your biceps tenodesis, these are 5 important methods where you can do it. One is an interference screw. You can either use a bio or a peak screw. Then there are special tenodesis anchors and tenodesis screws. A lot of companies have made tenodesis screws, which are there. Tenodesis anchors are also there. But there are new technologies which are called as all suture anchors, and they are very helpful nowadays and commonly used for doing a biceps tenodesis. And then there is a no anchor technique, which is called as a keyhole technique. So a lot of surgeons have come up with different techniques, and we'll talk about these techniques as we go through our presentation. I think interference screw has been conventionally done. We have been doing interference screw for so many years. Usually we used to make a tunnel which was around 8 millimeter tunnel. Anything which is more than 6 millimeter on the humeral side is a problem, because that is going to ultimately pose a lot of pressure onto the humeral cortical bone and predisposed to fractures. And that is a reason that you should not make a large tunnel for the interference screw. So we usually use a smaller tunnels for the interference screw in these cases. I'll just stop in a minute. My laptop is going into sleep mode. I'll just put a battery. 1 minute. Yeah, the battery is connected. Yeah. So interference screw is a conventional technique. We used to use 8 millimeter humeral screw, but now we have actually started moving away from the interference screw because of the reason it's a cortical bone, and if you breach the cortex, it creates a high area of stress riser, and ultimately there are chances of fracture to happen. Then there are tenodesis button, which is something like an endo button. You can actually flip it onto the posterior cortex, and as you are going to make the endo button loop smaller, the tendon can go into the socket. So with an endo button, you make a small tunnel, you use a small screw to fix it. It's a bicortical fixation, one on the posterior aspect, one on the anterior aspect. The problem with this kind of tenodesis buttons are that there is an axillary nerve in the back, and there are chances of axillary nerve damage in such patients. So again, if you see our practice, we started with the interference screw. Then because there were fractures which were reported, we moved from interference screw to a endo button, something like a tenodesis button. We used to flip it on the posterior part of the humerus and then make the loop shorter by cycling it and putting another screw on the anterior cortex. This was a double cortical fixation. But there were incidents of axillary nerve which could be damaged, because when you penetrate the posterior humeral cortex with a drill bit, there might be chance of an axillary damage. So we started moving away from the tenodesis button as well. If you compare the biomechanics between the interference screws as well as these anchors or the anchors, the third one is the anchors. Now these are anchors which are available. You do a cortical fixation putting in anchors. People feel that when you put an anchor, there are chances of it to pull off. And there are biomechanical studies, especially while cyclic loading. And they tell that interference screw is more reliable than the suture anchors, because the tendon goes into the tunnel and the fixation surface area is much more. So when you do cyclic loading in these patients, definitely interference screw is much more reliable than the anchor, which is usually a cortical anchor, which just holds it on the cortex. But when you see avulsions, which is actually called as the failures are equal, more or less. So I think depends upon your technique, whichever you want to use. You can either use anchors or even the screws. It is definitely a surgeon's choice. If you want a very good initial fixation, interference screw definitely has much more better chances than the anchors. As far as long-term outcome is concerned, I think a lot of these patients have been tested for range of movement and patient-reported outcomes with suture anchor fixations. And they have been actually comparable with almost all the techniques of interference screws and keyhole techniques and tunnel methods. And that is the reason that we have started moving away from interference screw, away from the tenodesis buttons. And now the latest things are suture anchor fixations. Though the initial strength is much less, so you have to protect the suture anchor fixation initially for 4 weeks to 6 weeks. But overall, the outcomes of the patient reported outcomes as well as sports injuries, they do very good with suture anchors. The latest suture anchors which we commonly use are all suture anchors. We have understood that if you make a double cortical or a big cortical hole, there are chances of fractures to happen. So with an all suture anchor, you don't do a double cortical kind of holes. You do just a unicortical medullary fixation. And the comparison strength of these kind of all suture anchors, which is essentially all fiber anchor or a suture anchor, is compared to all other techniques as well. So as you have grown our practice, we have now shifted entirely to all suture anchors. We don't no longer make cortical holes or tunnels. We no longer put buttons to do a biceps tenodesis. We don't use superficial anchors also to do tenodesis, something like a peak anchors or something. Our latest anchor are all suture anchors. And these have actually changed our practice because it becomes much more faster to do it. The fixation is good. The chances of both the radial nerve damage as well as the humeral fractures are mitigated. And the strength and outcomes are comparable to all these techniques. So this is the latest which is commonly used now. These are all suture anchors called as a biceps all suture anchors which are commonly used. So how does that function? We always stitch the tendon, that is stitched with our Krakow stitches. Then we make a small unicortical hole. It's not a bicortical hole, it's just a small unicortical hole. And with the unicortical hole, you put your anchor inside, which is a all suture anchor. It's got a Chinese finger trap kind of mechanism, and all suture anchor goes in. And all suture anchor is a tensionable technology, which means there are different sutures to pull your tendon towards the bone and then to tension it. So once you are going to pull, your sutures of the tendon would go through the anchor out. And when you load into the tensioning loop, as you're going to pull the tensioning loop, everything tensions very strongly. So as I'm going to tension the tensioning loop, everything just goes and sits solidly over it. And then you can maybe put a 1 or 2 backup knots like that. So it's a superficial cortical fixation, but the fixation is inside the endosteal part of the bone where the button is the all suture anchor is going to sit. And the sutures are going to give an initial holding to this tendon. And ultimately, this is going to heal. And all, as I told you, the cyclic displacements, the stiffness, and ultimate load to failures, everything is actually comparable with their older techniques. So our latest technique of doing a biceps tenodesis is using an all suture anchor. As I told you, they are actually very stable in cyclic loading. It actually maintains the proper tension when we are tightening it. Our rehabilitation has to be controlled because you have to actually get the bone and tendon to heal. But initially 12 weeks, if you do a very good fixation in around 3 months time, it actually heals very, very well. So that is why now our rehabilitation actually starts within 3 to 5 days after surgery. We put the patients in an elbow sling, keep it flexed, and then gently the patient is going to take it out of the elbow and achieve full extension in a couple of days. We avoid full range of movement or active elbow flexions till around 4 weeks or so. You don't want to give any tension to the tendon. So around 4 weeks or so, patient is not lifting any heavy weight, getting too much of elbow flexion done. don't push too much extension, and don't do a lot of hard supination for 4 weeks or so. And that is why we usually give them a pouch or an immobilizer for 4 to 6 weeks. Biceps is a very strong muscle. If you actually fix it and just leave it like that, the chances of re-tear are very, very high. So we usually be a bit slow for 4 weeks or 6 weeks. And then when the patient is out of immobilizer, then rehabilitation is actually accelerated. More often than not, we have also seen a lot of patients with chronic long head of biceps tears, and they are coming after a couple of days, even a couple of months also. And these patients often require more dissections. So some of these patients would require actually 2 incisions, one proximal incision and one distal incision. Distal incision is to actually find where the tendon is and then reroute through a tunnel to the proximal incision and then try to fix it at the anatomical site. In some cases, we have actually used a hamstring graft to augment the tendon, which was bad quality. And we stitch that hamstring graft to the muscle tendon junction, and then we do a tenodesis onto the inferior part of the groove. So these patients are symptomatic. Chronic tears are symptomatic, especially they are young active people, and they usually have a lot of cramping sensation. They are unable to do gym activities. And when you do chronic tear repair, the outcomes are quite good, and these patients actually heal well. But you should be mentally prepared to give a small, larger incision in form of a proximal dissection. And if you are unable to find the tendon in the proximal dissection, you might also have to do a distal dissection to get the muscle out by belly out, and probably use a hamstring graft to augment a chronic long head of biceps repair. Now, overall, when you do a biceps, as I told you, these are 6-7 complications which are commonly seen. Humeral fractures are seen. They were common when you used to use interference screws. Nowadays, it is not very common because we have shifted from interference screws onto a anchor. Biceps cramping does bother patients. A lot of these patients have biceps cramping, but it is usually seen more if the patient's previous surgery has failed, so it's a revision case, or if the patient is coming very late and we are doing a chronic biceps repair. In such patients have biceps cramping. If it is an acute biceps rupture and you are able to do it in a couple of weeks, they don't have too much of biceps cramping. Infection has to be taken care. Some patients often have pain in the front of the shoulder at the incision site, but usually it happens when you do a lot of retraction there, and there is a lot of soft tissue damage which is happening. Stiffness and re-rupture are also common, especially when the patient comes after a chronic tear. And if you do a chronic repair, these patients tend to become a bit more stiff, and there are chances of re-rupture because the collagen quality is not so great. But overall, the satisfaction rate after a long head of biceps rupture is very, very good. And patients are very satisfied both functionally as well as cosmetically. Thank you very much.
Thanks so much, Professor Oberoi, for this very interesting presentation. Thank you so much, sir.
Thank you.
Thank you very much,
sir. Srinivas, you are the moderator of this part of the session, sir.
Thank you very much for the clear and comprehensive presentation on all the different types of fixing, sir. I don't think we have questions yet from the, we've got one actually. Is there a specific, from Dr. Gamal Qasim, is there a specific maneuver to deal with the cramps? He's asking.
So yeah, we initially thought that the patients would get well with the just giving them an immobilizer for initial days and then probably putting them on rehabilitation. But we have found that the cramps is something which patients actually keep on getting bothered for a long, long time. We have not found any final solution for the cramps. But what we have found is that if these patients have actually reported early after their rupture, the cramping is much less. But if these are chronic tears, they do have cramps, and there is actually no solution to all of these biceps cramps, which actually get well in a couple of months, but it still bothers these patients for at least 6 to 9 months or so.
I have a couple of questions, sir, if that's okay. How do you assess the tension on the biceps and assess the length, where to cut and fix it?
So I think, as I told you, the muscle tendon junction is important. So if you see the muscle tendon junction, you don't want to shorten that muscle tendon junction. Don't want to pull it quite up. You have to have a nice 3 centimeter of this muscle tendon junction. So Over and above, you can actually exercise that part. When you stitch it, the last part should be around 3 centimeters of muscle tendon junction, which should correspond, as I told you, close to the inferior part of the bicep screw. So you then don't over tighten it or you don't leave it lax. The arm position can be electively. There are people who have been putting it in extension and getting good results. There are surgeons who are putting it in flexion and they are also getting good results. But overall, anatomical landmarks are important. You don't assess the tension there itself. You just try to put it anatomically as the dissections have told us. And most of these patients usually get good tension. Anyway, because short head of biceps is there and then some fibrosis is going to happen there ultimately. So you just restore anatomy. You can't assess the tension. Patient is under general anesthesia. It's already muscle relaxation is given. So you can't actually, you have a tendency to over tighten it, and that is bad. So that is the thing. No, don't over tighten it.
With respect to the technique using the interference screw, what size of interference screw do you use in relation to the drill hole? That's one question. The other one is, how do you put the tendon inside and maintain it when you're putting the interference screw?
So that used to be very challenging, and that is why whenever we used to put interference screw, the tendon never used to come out. It was the sutures which were going in. And that is why the interference screw was modified to a biotenodesis kind of interference screw.
Yes.
It was something like a fork. So the companies came out with a screw which had got a fork in front, and you used to load it through the anchor. So on the fork itself, the tendon would sit, and then you will guide that fork into the tunnel base, and then put the screw over it. So it used to be something like a fork down, a tunnel, and a screw over it. So fork would just keep it down, and your screw would come it. So that was a tenodesis kind of screw. The typical biotenodesis screw which came out was a forked tenodesis screw, because the tendon would not go out. Because as you were pulling it, sometimes the tendon would come out, you would just end up putting on the sutures. So the design was like that. But we have actually moved out from a tenodesis screw now. We don't use it. We use it sometimes when we are doing arthroscopically, especially when you are fixing it at the upper part, close to the articular surface or the superior part of the groove. But as we come inferior part of the groove, it's more cortical bone, and you don't want a 6, 7, or 8 millimeter size stress riser there.
And the size, the diameter of the screw in relation to the drill hole, sir, for the interference screw?
Companies have made the screw size from 7 to 9. But I think even 7 is a bigger screw, especially for the subcontinent where we are staying. The proximal part of the arm is actually very, very narrow, especially in the area of biceps groove. And so even 7 is not a good idea to make a hole there.
Okay, thank you. Professor El-ashhab wanted to ask a few questions, I think.
Yes, sir. Please, sir. Thank you so much. Thank you so much. Professor Oberoi, do you think that in such cases there is a rule for conservative management, sir?
Yes, definitely. I mean, those who are not into active lifting, overhead activities and active elbow flexion activities, they have a role of conservative therapy. Sometimes we actually ask the patients to wait and watch for a couple of weeks. Though we understand that the surgery is going to become more complex, but sometimes they are not very happy with the Popeye sign. They don't feel good. Sometimes they feel their elbow flexions are weak. They would come back and ask us to do a surgery. Or even sometimes they have a lot of biceps cramping and they are bothered and they want us to do surgery. But yes, if he is not an active athlete, especially into heavy weight lifting, there is definitely a role of conservative therapy. Brachialis muscle is there, shorter head of biceps is there, elbow flexion power is quite good. Supination is something which is a bit weak, but most of people are able to cope up.
Yes, sir. And what's the role of arthroscopy in biceps tenodesis, sir?
So arthroscopy in biceps tenodesis is commonly done when we have an associated cuff tear. So if it is an isolated biceps rupture where there is no cuff tear, just biceps, they lifted the weight, the longer of biceps ruptured and it just got down, we just go ahead and do a subpec tenodesis after an MRI for sure. But in a degenerative condition where the biceps is also degenerate and then there is a cuff tear also, most of the time it is associated with cuff tear. There is no history of trauma. They just have pain. They are unable to lift it up. And when you do an MRI, you find that the subscap is torn. The biceps is actually shredded, sometimes even torn. And these are the patients where arthroscopy is also very important, because then you have to address both the pathologies. In such circumstances, you often find biceps, flimsy biceps there. And if you want to do a tenodesis, you can actually pull it up and as such do tenodesis at the area of articular surface or just at the superior border of the bicipital groove. But arthroscopy is essentially for the cuff pathologies associated with the biceps rupture.
Yes, sir. And sir, if I found a concomitant subscapular tear, I do manage both tears at the same time?
Yes, that is the best thing to do. Subscapularis is a very important muscle. We have been underestimating that muscle. And whenever you have a biceps which is degenerate and torn, it actually goes out of the groove and goes into the subscapularis because that pulley is gone. So there is a subscap leading edge tear. If it could be a partial tear, it could be a complete tear. Depends upon the pathology. But arthroscopy has a role of identifying that tear, fixing that tear, and then adding on a biceps tenodesis. Some people would do a tenotomy and then do a subscap repair. Some people would do a tenodesis so that the part of the tendon is out now or already tenodesis, and then you can address the subscapularis. But often seen with degenerative conditions, not as a traumatic lesion. Traumatic lesions, isolated biceps is usually in heavy weight lifters. Some of them are using steroids also to get and their tendon quality is bad, and they suddenly have a pop and they have a Popeye sign, and then they run towards an orthopedic surgeon to fix that up.
Yes, sir. Thank you, sir.
So between
Srinivas, we have any other questions, sir?
Yeah, just one more. Between tenodesis and tenotomy, what factors would you consider to take the decision?
So I think these are 4 factors which are important. First factor which is important is the activity level of the patient. Second factor is important is the physiological age of the patient. Third factor important is dominant and non-dominant hand. And fourth factor which is important possibility is chronicity of an injury. So you need to sit and talk with the patient because if it is a patient which is a heavy worker, then these patients might need biceps tenodesis rather than tenotomy. If it is a dominant hand, again tenodesis rather than tenotomy. If this is a patient which has got an acute tear, possibly tenodesis would help. If it is a degenerative tear, better do a tenotomy. So you have to talk with the patient regarding that, and especially heavy workers, gym athletes, again try to do tenodesis than tenotomy. Tenotomy is 5 minutes job. Tenodesis is 10-15 minutes job. So if you are willing to spend 10-15 minutes and you have a good quality of 10, rather go ahead and do it. It's a good surgery actually.
Thank you very much, sir. Thank you very much for the talk and the discussion. We'll go to the next section of the presentation. Professor
Thank you so much, sir. Thank you so much, Professor Srinivas. Thank you so much, Professor Oberoi, for this very illustrative and interesting presentation. It's an honor for us, sir. Thank you so much, sir. Now we will move to the next part, the second part of our session tonight with Professor Amr Rashwan. Professor Amr will speak about the irreparable rotator cuff tear. Professor Amr is a professor of orthopedic surgery, Cairo University, and he's one of the very active members of the faculty of the Egyptian Arthroscopy Association and the Egyptian Shoulder Association. Professor Amr, please. Sir, you are muted, sir. Professor Amr, you are muted, sir.
Thanks,
yes,
Dr. Mohamed El-ashhab.
Thank you, sir.
For giving me the chance to participate in such a marvelous educational course. I will talk about the irreparable rotator cuff tear management. As we all know, the effect of the rotator cuff deficiency, we lose the centering force of the humeral head on the glenoid. which consequently will lead to a superior humeral head migration, destruction of the glenohumeral cartilage, a superior glenoid erosion, a synovial leakage, an osteoporosis, a humeral head destruction, and articulation with the acromioclavicular joint with subsequent acromioclavicular joint destruction. This is a vicious circle in which the rotator cuff tear will cause the loss of the centering force on the humeral head with subsequent upward pull of the deltoid on the humeral head. And so the humeral head cannot be held against the glenoid with a subsequent diminution of the acromiohumeral distance less than 6 millimeters. This subsequently will lead to an abutment of the humeral head against the acromion, subsequent stabilization of the acromion, and ending into a rotator cuff arthropathy. Our main aim in the rotator cuff repair is to attain an anatomical repair to the footprint, which is usually tried to be achieved in active patient in the absence of severe degenerative changes. Let's go through a clinical case scenario. A patient, 65 years old, she is hypertensive and diabetic. She underwent a rotator cuff repair for her left shoulder 6 months ago with no improvement in the range of motion since the operation and in spite of several sessions of physiotherapy. On examination, she had a limited abduction, less than 45 degrees of active elevation, and limited forward elevation with limitation of internal rotation and external rotation, with subsequent twisting of supraspinatus and infraspinatus. She is suffering from a pseudo-paralytic shoulder. The pseudo-paralytic shoulder is described as a normal passive range of motion in the presence of a massive rotator cuff tear with a less than 45 degrees to 90 degrees of active elevation. This is our patient, and this is her imaging. As we can see here, she had a complete atrophy of the supraspinatus and a retraction of the rotator cuff rim to the glenoid edge. This is her video arthroscopy. As we can see here, there is a complete degeneration of the cuff, which is at the glenoid edge. And after doing the releases, it couldn't be attained more than the glenoid edge. We had performed a reverse shoulder arthroplasty for this patient to achieve a better shoulder function. And this is her follow-up after 1 year. And this is the patient, and this is her follow-up. Another case, male patient, 48 years old. He's an active manual worker. He sustained a fall from a height during working on the ladder. And he fell with his right arm catched on the ladder steps 1 year ago. He's complaining of loss of ability to abduct, flex his shoulder. On examination, he had the limited abduction, flexion, external rotation. However, there is some wasting of the supra and infraspinatus. As we can see here, his rotator cuff at the edge of the glenoid with wasting of the supraspinatus, as we can see. We had done him a lower trapezius transfer with lengthening of the lower trapezius tendon, which had a short excursion with the semitendinosus tendon harvested from the knee and then taken arthroscopically assisted to be fixed in the superior aspect of the greater tuberosity. And here is the patient after 1 year of physiotherapy. There is still some limitation on the right side, but this is a function for a young patient. We have 3 unequal description: a massive rotator cuff tear, an irreparable tear, and a pseudoparalytic shoulder. The massive rotator cuff tear, as described by Gerber, it is an involvement of more than 2 tendons of the rotator cuff in the tear. Hopfield had described a more than 5 centimeter retraction and an exposure of 65% of the greater tuberosity. An irreparable rotator cuff tear is described as a tear, which is impossible to achieve an anatomical fixation in 60 degrees of abduction in spite of an adequate tendon release, as described by Gerber et al., a retraction to the glenoid edge, a superior escape with an acromiohumeral distance less than 6 millimeters, or a Hamada classification, an acetabilization of the acromion, which is a rotator cuff arthropathy, a fatty infiltration, Goutelier grade 3 or 4, a muscle atrophy and decreased elasticity, and a weak external rotation. Finally, the last description is a pseudoparetic shoulder, which is a patient suffering from a normal passive range of motion in the presence of a massive rotator cuff tear with less than 40 to 90 degree elevation without active external rotation or internal rotation. So why a functioning shoulder turns into a non-functioning shoulder? This is related to the loss of the force couples around the shoulder, mainly the vertical force couple and the horizontal force couple. The vertical force couple is formed between the deltoid upward pull and the supraspinatus, and the horizontal between the subscapularis anteriorly and the infraspinatus anterior minor posterior. Such a this imbalance, when it is in the vertical orientation, there is an isolated loss of elevation because the deltoid is functioning while the supraspinatus is weak, and this will lead to a superior escape of the humeral head. A horizontal imbalance, usually there is an isolated loss of the external rotation if the infraspinatus and teres minor are involved, while the subscapularis, teres major, and pectoralis major and latissimus dorsi are still functioning. Another form of horizontal imbalance is the isolated loss of internal rotation when the subscapularis is affected while the infraspinatus and teres minor are still functioning. And finally, a combination of horizontal and vertical imbalance in which there is a combined loss of elevation and external rotation. And here there is an involvement of the supraspinatus, infraspinatus, and teres minor. The horizontal and vertical imbalance usually cause the loss of the spatial orientation of the upper limb in the space and inability to stabilize the arm or to prevent it from drifting into an internal rotation. So the loss of horizontal or vertical imbalance with Quillen classification with the involvement of the supraspinatus, infraspinatus, and teres minor lead to a posterior-superior escape, and the loss of the supraspinatus subscapularis anteriorly will lead to an anterosuperior escape. This is the summary. This is an isolated loss of elevation, an isolated loss of external rotation, an isolated loss of internal rotation, a combined loss of elevation and external rotation as described by Scalp-Quillen. So we had four forms as we had described for a non-functioning shoulder. Our treatment option for a massive irreparable rotator cuff tear could be a non-arthroplasty option, an arthroscopic debridement with a reverse subacromial decompression of biceps stenotomy, a partial rotator cuff repair, a balloon spacer, superior capsular reconstruction, a tendon transfer, and arthrodesis with a reverse shoulder arthroplasty as the arthroplasty option. And finally, a non-operative treatment for those who are unfit for surgery. Let's go for discussion for our options for a massive irreparable rotator cuff tear. The non-operative treatment, putting into consideration a failure rate of 70% after rotator cuff repair for massive and chronic rotator tears, and putting into consideration as well the pain relief and the function improvement does not necessarily correlate with the successful structural healing of the tendon, is mainly indicated for a traumatic rotator cuff tear. This could be achieved through an anterior deltoid re-education program to rehabilitate the deltoid muscle to compensate for a deficient rotator cuff. The arthroscopic debridement with a reverse subacromial decompression, or what's commonly known as tuberoplasty, this option is needed to protect the coracoacromial ligament, which is a structure at risk in the regular subacromial decompression, to prevent the anterosuperior humeral head escape while ensuring a smooth acromiohumeral articulation. And the biceps stenotomy is aimed as the long head of biceps tendon is a main pain generator in patient with a deficient cuff. So it is indicated mainly in patient with a low physical demand, sufficient residual shoulder function, and when the pain is the chief complaint. Its main advantages, it requires a shorter rehabilitation, and only it is a minor surgical risk. But it has a higher failure rate over time, and a discomfort and function deficit could be achieved later on. A partial rotator cuff repair is one of the non-arthroplasty options for a massive irreparable rotator cuff tear. It aims to restore the rotator cuff force couple anteriorly through the subscapularis and posteriorly through the infraspinatus and teres minor. This offers a sufficient concavity compression of the humeral head into the glenoid, which can be obtained by a balanced force couple, and so it prevents the superior humeral head migration. The advantage of this option is it has a reliable short-term outcomes in patients without a significant arthritis. However, the clinical outcomes may deteriorate over time due to the failure of the repair, and it requires a longer rehab. To go for the tendon transfer, it is mainly indicated for young patients without a glenohumeral arthritis, but with a functional deficit, especially external rotation. The main advantages of the tendon transfer, it is a standardized surgical technique. It has a reasonable outcome in a relatively young patients, and it restores an active range of motion. However, it requires a high patient compliance and a long and complex rehabilitation. As we discussed before, the four non-functioning shoulder patients, the isolated elevation, isolated loss of external rotation, the isolated loss of internal rotation, and a combined loss of elevation and external rotation. We have 5 principles for the tendon transfer. We need an accurate positioning of the transfer tendon, a physiological tensioning of the transferred muscle tendon junction, a strong bone fixation of the reimplanted tendon, a minimally invasive surgery to reduce the muscle scarring, and a synergistic transfer. So how we can restore the vertical balance? The first option is to have a latissimus dorsi transfer with a superior fixation on top. For restoration of the horizontal balance, as to say, recreation of the infraspinatus and teres minor, our first option is El-Bosco transfer, or a modified El-Bosco transfer through a combined anterior incision, or a lower trapezius transfer as described by Bassem Al-Hassan. Why the lower trapezius transfer is much better? Because biomechanically it is superior to the latissimus dorsi transfer for restoration of the glenohumeral mechanics and the joint reaction force. It offers a better abduction and external rotation compared to the latissimus transfer. The tension and the excursion forces of trapezius are very similar to the infraspinatus. However, it carries the risk of a seroma formation due to the subcutaneous tunneling under the deltoid. This is the technique originally described by Bassem Al-Hassan, a lower trapezius transfer, but it carries the problem of a short excursion of the lower trapezius, which can be lengthened by an allograft Achilles tendon or an autograft of a semitendinosus or gracilis harvested from the knee and then taken to the fixation point on the greater tuberosity. How we can restore the horizontal balance to recreate the subscapularis? This could be achieved through a pectoralis major transfer, but we should take care that the pec major is from the anterior chest wall, so it needs to, during tendon transfer, needs to be passed under the conjoint tendon. As we can see here, the pec major is passed under the conjoint tendon to act as a subscapularis substitute. And how to restore the vertical and horizontal balance? This could be achieved through a reverse shoulder arthroplasty, but this corrects only the vertical imbalance, not the horizontal balance. So we can have an active forward elevation, but with no rotation, and this is the price which need to be paid. Why the latissimus dorsi alone can fail to restore the horizontal and vertical imbalance? Because of the rules of tendon transfer, a one tendon, a one transfer, and a one function. So in the pseudoparalytic shoulder, we had at least 2 tendons injured, so the latissimus dorsi cannot provide a perfect solution for the horizontal and the vertical imbalance. So to restore the vertical or horizontal imbalance, we need to do either a reverse shoulder arthroplasty with Nice El-Posco transfer. We can have a biological lateralization, a bio-reverse shoulder arthroplasty, or the third option to get a lateralized reverse shoulder arthroplasty. This is the tendon transfer combined with a reverse shoulder arthroplasty to improve the rotation range of motion, not just the active forward elevation. Another option for a massive irreparable rotator cuff tear is the superior capsule reconstruction. Here, the graft prevents the superior migration of the humeral head, maintaining the fulcrum if the forescapula is still intact. Many options have been used for the superior capsule reconstruction: the fascia lata, the biceps tendon, the acellular human dermal allograft, indicated mainly in patients with a pseudoparesis, an intact or a repairable subscapularis tendon, and absence of an external rotation laxum. However, it is contraindicated in high-grade osteoarthritis, deltoid weakness, and irreparable subscapularis tears. Another option is the subacromial biodegradable spacer. The aim is to depress the humeral head to a more central position on the glenoid, so restoring the forescapula and increasing the deltoid load to improve the deltoid lever arm. However, it is contraindicated in advanced cuff arthropathy, Hamada grade 3 or higher, patient with an irreparable subscapularis tear and pseudoparesis. Our final option is the arthroplasty option, the reverse shoulder arthroplasty. It is mainly indicated for massive irreparable rotator cuff tears in the elderly and rotator cuff arthropathy with a decreased acromiohumeral distance. The main advantage of a reverse total shoulder arthroplasty is that it has a very good outcome on the short and mid-term follow-up. It requires a shorter rehabilitation and a considerable scientific evidence supporting the use of reverse shoulder. However, it has a limited use in younger patients with some functional deficits related to the arthroplasty design and a limited load-bearing capacity. This is the principle on shifting or medialization of the center of rotation. Gramont in 1985 had described a medialization of the center of rotation. This helped to recruit more deltoid fibers, especially in the pseudoparetic patients, and this decreased the torque of the glenoid components. However, it increases the scapular notching, but decreases the range of motion. The lateralization of the glenosphere, introduced later on, allows a decrease in the scapular notching, a better passive external or internal rotation, and a better cosmesis. But it carries the risk of increasing the torque shear forces at the base plate glenoid interface, which increases the failure rate of the glenoid component. To summarize, our algorithm in younger patients with a posterior superior cuff affection, a tendon transfer is a valid option, a lower trapezius transfer, an El-Posco transfer, a partial rotator cuff repair, or a superior capsule reconstruction. Regarding the anterosuperior cuff affection, the tendon transfer is there. However, in older patients, a non-operative treatment, a subacromial biceps tenotomy, a balloon spacer, superior capsule reconstruction is there, with a partial repair and reverse shoulder arthroplasty. My take-home message, a proper patient examination to detect those with pseudoparalysis. A reverse shoulder arthroplasty is still a marvelous solution for patient with cuff arthropathy, but it can be non-functioning regarding the internal or external rotation. Tendon transfer is technically challenging and need a long experience and a proper patient selection for each option. Thank you so much.
Thank you so much, Professor Amr, for this very interesting and very illustrative presentation. I think you have discussed all the topics regarding the irreparable rotator cuff tear. Thank you so much, sir.
Thank you.
We have 3 questions from our dear attendees. First question from Dr. Mohamed: how to differentiate between the isolated ILEA, isolated external rotation loss, from progressive external rotation loss clinically what the differential group of muscles involved and the treatment for them.
For the isolated elevation?
Yeah.
The isolated elevation depends mainly on the effect of the supraspinatus. So testing the supraspinatus carefully will help to illustrate that it is an isolated elevation deficit only, while testing the subscapularis anteriorly and the infraspinatus anterior minor posteriorly, we can clinically confirm our diagnosis.
Yes, sir. Another question from Dr. Gamal Qasim is there is a minimally invasive maneuver in the to minimize pain in all patients unfit for arthroplasty?
Yes, the minimally invasive surgery could be just doing a debridement, a reverse subacromial decompression, and a biceps tenotomy. As we had said, that the long head of biceps tendon is a main pain generator. So this can be relieved with a minimal surgery.
Yes, sir. The third question from Dr. Abdullah, the cost of implant of arthroplasty, I think it's now very expensive.
Yes.
Reverse the shoulder. Yeah. A question from me, sir. Do you prefer, if you have a case that's a candidate for reverse shoulder, do you prefer to start with shoulder arthroplasty, or do you try another non-invasive measure before going to arthroplasty directly?
If the patient is having an advanced rotator cuff arthropathy and a patient suffering from a pseudoparalysis, I think the main option will be the arthroplasty option. If the patient is younger, if the degree of arthropathy is still starting, then the tendon transfer is there, or a partial repair could be achieved.
Yes, sir. And do you think that still there is an option for arthrodesis, sir, after the reverse shoulder is going up in the era for management of such cases?
I think an arthrodesis is a horrible option, but it is still there.
Yeah. Yeah. Professor Oberoi?
Yeah, just a small comment. I mean, Dr. Amr, are you using biceps also for SCR or using a facial lata usually?
No, I had shifted. I had tried some cases in Mihata technique, but I couldn't achieve a desirable success. So I shifted into the biceps tendon since 2 years. I have done around 20 patients now. I think it offers a very strong graft with a less use of anchors. You can use just 2 anchors, and then you can do a side-to-side convergence and achieve a better repair.
Yes. It's a very thick graft. It's a vascular graft. It is available locally. And I think, as you rightly said, 20 cases, and I think, it speaks itself that it is a really good, if you have a healthy biceps, use it.
Yes. Unless the tendon is completely frayed or completely damaged, then it is not an option in this case.
And when you do a biceps SCR, would you do a tenotomy and then shift the biceps, or you do a biceps SCR in continuation? You just take it out of the groove and in continuation just pull it on the superior aspect.
No, I don't do a rerouting for the biceps tendon. I just divide it and then I reattach it on an anchor on the lateral aspect of the greater tuberosity.
Yes.
And how do you decide where to attach the biceps?
Please, sir.
I reattach the biceps tendon at the most, as far as I can, laterally, in order to be able later on to get a side-to-side convergence of the remaining cuff over the biceps tendon.
Yeah, biceps is usually anterior, so you have to reroute or you have to cut and bring it more towards the posterior, superior, and lateral, so that it actually helps as humeral depressor as well, and also as an interposition between the acromial end. So it can't be anterior, so you have to actually shift it more a bit posterior and fix it more laterally. So it actually functions very nicely.
Yes. To act as a depressor, as you had said, Dr. Oberoi, over the humeral head, as well as
interposition.
Yes.
And the force couple has to be restored, rightly said. Subscapularis and infra, they have to be restored so that when you have a biceps SCR, the function then happens.
Yes. So as I demonstrated, without an intact subscapularis or a reparable subscapularis, this could not be achieved because you will lose the force couple.
And Professor Amr, do you have an experience about the in-space balloon? Because we don't have in-space balloon in India right now. It is yet to be approved by the local FDA. We are launching it, I think, this year, but we don't have any experience ourselves of putting these in-space balloons.
No, we don't have this option in my country because it's not registered in our company. But I think the spacer, which start biodegradation within 3 months, I think the force couple will not be restored in such a short duration. And also the inflation of the balloon spacer with saline, there is no shortcut point for it. I think it is, if it is underinflated, it can be dislocated anteriorly or posteriorly. And if it is overinflated, it will act as a stone over the humeral head and under the acromion.
Maybe initially it will just protect. If you do a repair and you can just protect it with balloon initially, and then the function of balloon would go after 3 months, 4 months.
Yeah, if there is an achieved repair, but as a sole option, no. I don't think so.
Yeah, agreed.
So after the repair, would you do a subacromial decompression, sir?
After doing a repair, I tested the space. At first, if the space is so tight, then I will go for an acromioplasty, but this is not routine. As recommended with the American Arthroscopy Association meeting, now a routine acromioplasty is not indicated in all the cases of rotator cuff, no longer.
CA ligament is pristine. I mean, if you cut that CA ligament, you actually it's not good for a bad cuff repair. So
yes,
you have to protect the
I preserve the coracoacromial ligament.
Always. So it is gentle acromioplasty, maybe just spur removal and maybe small osteophyte. It is not radical, which you used to do before that. It was too much of.
At 20 years ago, we had been so aggressive in addressing the undersurface of the acromion.
Yeah, everything was Bijlani 3. We made it Bijlani 1.
Thank you so much, sir. I think we have no more questions. Finally, I would like to thank Professor IPS Oberoi.
So is there a place for treatment algorithm?
Excuse me, please, sir. You have a question, Dr. Srinivas?
Sorry, I think my connection has been a bit slow.
Can you hear me, sir? Yes, I can hear you. You have any questions, sir?
Okay. Just wanted to ask, is there a place for dermal allograft in the treatment algorithm for Professor Amr as well as Professor Oberoi?
So let me tell my experience. We started with the bovine collagen. They used to launch it like the TB matrix. That was not a very purified collagen. We did around 8 to 10 cases, and that had a lot of synovitis. So it was not a very refined collagen which was provided. That was the Arthrex company which used to give us TX matrix. And ultimately the company also actually took it out from the shelf. There are some other collagen products which are available commercially, but I think standalone collagen probably would not work. Something like a graft jacket. You have to have a tendon there. You have to have a tissue there to do it. This is just like an additional graft jacket which is going to just help you do it. So a standalone, as he rightly said, probably in-space balloons, standalone graft jackets, they don't work functionally. That's my experience. Professor Amr.
I agree with you, Professor Oberoi. There should be at least a partial tendon repair for such a collagen or dermal allografts or a space balloon to function there.
Thank you, sir.
Yeah. Thank you, sir. Finally, I would like to thank Professor Oberoi and Professor Amr Rashwan for their very illustrative and very interesting presentation. Many thanks to my dear friend, Dr. Srinivas, for his great and continuous effort to make this cooperation in this very good manner and very good picture. Thank you so much for your effort, sir, and hoping to see you next Friday with another two eminent speakers from India and from Egypt. And many thanks for your effort. Thank you so much, and have a nice time. Thank you so much.
Thank you.
Thank you very much.
Thank you so much, sir. Thank you, sir. Thank you. Thank you for your effort, sir. Thank you, sir.